Welcome to the other side of Lucy Letby. In episode 42, we're going to finish off the case of baby N. Remember, Letby has 3 indictments of attempted murder for baby N, and we have the prosecution opening statement and the agreed facts in episode 41. We'll look now at the other evidence that was given in this trial, and we'll also look at the expert evidence, particularly that of Sally Kinsey, professor of hematology, so that's blood diseases such as haemophilia, which this baby had. But before we can make sense of what everyone else says and how a jury could possibly come to a guilty conclusion on any of these indictments, we have to look at the expert evidence of Dowie Evans. From one doctor to another, I think Dowie Evans has really brought the medical profession into disrepute. Here's a man who goes into court, who invites himself into a murder trial, pretending in effect to be an expert in neonatology. He takes a stand, and under oath he claims that Lucy Letby murdered a baby C, by injecting her into the stomach. Later on, when the trial is over and the verdicts are in, he changes his mind and says that he doesn't believe that is what happened. People like me have tried to make the point from the very beginning that everything that Dowie Evans says has no backing in the body of knowledge that we use to make medical decisions. Most of these things that he comes up with are not backed up by our understanding of medicine, what has been documented about medicine in articles and teaching material. So much so that Lucy Letby is the only person in the history of the world who was found guilty for overfeeding a baby or injecting her or something else into a baby's stomach. This is the kind of stuff this guy has come out with. The defense tried to get Evans' testimony chucked out, but the judge was having none of it. But really, and particularly in this case, there is nothing, no one has any facts to offer, or even approximation of fact to offer, that would suggest in the slightest that Lucy Letby harmed baby N. There is also so much evidence given by the people in this trial, the witnesses that were actually there when the incidents were supposed to have happened. There's so much evidence they give which exonerates Letby. And so we have this bizarre situation where in the case of baby N, we have 3 indictments for attempted murder, and the jury finds Letby not guilty of 2 of them, but finds her guilty of the 3rd one. We'll have a quick look now and see why they didn't find her guilty of the first 2, and why they found her guilty, or why they likely found her guilty for the 3rd indictment, where the baby was very seriously ill and the team had to come from Alderhay to bail out the amateurs at the Countess of Chester Hospital. The first witness up in the Total Life Wiki, which again is the only reference I have, because the public record of this trial is a state secret, unless you happen to have £100,000 to pay for it. The first witness is Dr. Bownick. I think that's Bowmick. I think that's how you say his name. But anyway, he was a registrar, and he's reading a statement, or a statement is being read from Dr. Bowmick. And he says tests were carried out for baby N for haemophilia, and that was all discussed with the parents. And the baby was transferred to the neonatal unit because it was premature and would need incubator for temperature control. So we've talked about their failure, absolute failure to maintain the temperature in this baby. And then he goes on to say that the baby was intermittently grunting at 1 hour of age. Yet we are told by the prosecution that this baby was born in excellent condition, which was not unusual for babies born by cesarean section, which is very true. They can have fluid on their lungs. But again, that's not something that you simply dismiss. That's a problem. But he confirms that the grunting went on for more than 4 hours. And as that was the case, they did a septic screen because they assumed the baby had sepsis. And as the consequence of the prematurity and the very low birth weight and the difficulty and stress of the cesarean section birth, it's not in the least surprising that the baby had one episode where the blood intermittently became hypoxic down to 40%, with colour change noted, but had settled thereafter and did not need supplementary oxygen for very long. But that is likely not true. He likely did need supplementary oxygen for longer. And the doctor finishes off by saying by the 3rd of June the baby was fine and breathing and no respiratory problems. And then we have not one but two statements from Caroline Oakley. And the second statement is important, so it's put into the evidence of this trial so that we can put into the jury's mind that as long as you think you have placed the nasogastric tube in the right way and that it was in the right location, that it's no longer a problem. And that is a clear misdirection and a deliberate attempt to draw the jury away from any consideration of the nasogastric tube, which is very important to this case. Again, you have to refer to the last episode to understand why. But the rest of Caroline Oakley's statement is everything was fine with the baby, as usual. Then we get the next series of statements, which are Nurse Melanie Taylor. Even though she was the shift leader that night, she's only vague memories, and she doesn't recall the shift. And she was aware that baby N had a collapse during the night, but did not remember it happening or responding to it. And why would she? And then we have Nurse Sophie Ellis, very vague memory, doesn't remember anything except that the baby had haemophilia, and she knows from the notes that the baby had a collapse, but does not remember being involved in the efforts to stabilise the baby. She knows the collapse happened when Christopher Booth was on a break, which is strange when you get to Christopher Booth's evidence, because Christopher Booth in his statement is asked about the night shift he was on for June the 2nd and the 3rd. He said he remembered baby N because it was unusual for a neonatal baby to be a haemophiliac. He adds his memory of the shift is limited. He says he is almost certain he was caring for baby N that night, so he's not even sure if he was caring for the baby that night. And he's the person that Sophie Ellis is sure was on his break when the baby had the collapse. But he does recall, of course, that baby N was stable with oxygen saturations almost 100%, which is too high, and no abnormalities present. And he says it was likely on the hour when he left for his 1 hour meal break, saying he had no concerns. He handed care over to a nurse, but he doesn't recall who that nurse was, and obviously no one wrote that down, because they should be able to reference it in the notes, but they can't. When he returned from his break, he was surprised to learn baby N had become unsettled and fractious, suffering a desaturation. And he adds that he wasn't called back from his break for this desaturation, so he isn't even clear what happened that night. And obviously, the note keeping isn't very good all round. And then we have Nurse Valerie Thomas, She can't really remember the shift, but she knows she was on that night, and she says she was likely working in nursery room 3 or 4. So she's no memory of the shift, but she does know that the baby had a collapse when Nurse Booth was on a break. And she said it was very unlikely she would have been involved in any subsequent care. But surely again, the notes would tell you that. And then an unnamed nurse, who cannot be named for legal reasons, said in her statement she remembers being shocked. Well, she mustn't have been working on a neonatal unit for very long. And then we have an Elizabeth Morgan, who is a healthcare advisor. And she was asked by Cheshire Police whether Miss Letby's failure to alert other medics that fresh blood had been aspirated from baby Anne's mouth that day fits with good practice. And Miss Morgan said, in her professional opinion, it would be standard good practice to escalate anything unusual, first verbally, and then later record it. This is a classical bureaucrat, give them the answer they want type response. The truth is rather different, however. The bleeding record from 10 a.m. is recorded 1 ml fresh blood, recorded aspirates from NG tube on the intensive care chart. So it is in the medical record. And it's there 2 hours after the failed attempt to intubate the baby. But Letby sent in a Facebook message to Dr. A, I believe, Loverboy Trader, I think that's the guy, I'm not sure. But she sends a Facebook message to this guy at 11:29 a.m. telling him small amounts of blood from mouth and 1 ml from nasogastric tube looks like pulmonary bleed on x-ray, i.e. bleed from the lungs. Given factor 8, wait and see. So what that tells you is that the medics had already been aware of the bleed, and as a result of their awareness of the bleed, they ordered an x-ray to check that it wasn't coming from the lung, and they gave the baby factor 8, which is the factor that's missing with the haemophilia. So they thought it was due to the haemophilia, and it could well have been due to the haemophilia. And they go on then, this prosecution, to say that other than the phone message, there's no evidence that Lucy Letby brought the bleeding to the attention of any of the medical staff. Well, she didn't need to bring it to the attention of the medical staff because it was a medical problem that they were well aware of and that they were looking for the source of and that they were treating. In these charts, there are nursing notes and there are medical notes. If the notes contain no mention of that bleeding, that's the fault of the medics, not the nurses. Surely someone wrote down the reason for the x-ray request, the reason for the administration of factor 8, because they're medical problems, not nursing problems. Ms. Morgan's statement seems to me just part of the story. The storytelling that is the essential basis of this trial. There's so many substandard things in this unit that the one thing that they're going to pick out and paper to the wall is some kind of alleged failure by Letby to tell someone that the baby had aspirated blood through the NG tube. That's the only criticism levelled at Letby by the state. People going on breaks and handing babies over to designated nurses, but not recording who they did hand them over to. People who are not sure who they were looking after that night because it wasn't recorded. None of those very serious things in terms of a medical legal document, a record of care for the baby. Do Cheshire Police ask Mrs. Morgan or Miss Morgan to give her opinion on? Well, they can have mine. It's lousy note keeping, and it can't be relied on for anything. We know from the incident that there is no mention of blood in the nasogastric tube until the 15th of June, and that on the 14th of June, when Letby wasn't there, the baby had clearly deteriorated clinically. And the baby was very unsettled. We remember that Lucy Letby was an early riser. She was up at 10:05 and she was texting her colleague at work. And her colleague at work said that the baby looked shit and had been very unsettled, mottled and veiny all of the night before Letby was to come on, and that the baby had a slight abdominal distension. And blood tests were taken for analysis. But we have no blood gas reading here at all. We don't know what the respiratory status, what the electrolyte status, or the pH of the blood was. We don't have that in the record. So I'm assuming that they didn't measure that, even though the baby was clearly not perfusing very well. This accumulates at 7:15 with a major intermittent hypoxic event, which would have been predictable. The prosecution actually stated in the agreed facts that this happened when Lucy Letby had visited her friend Jennifer Jones Keys at roughly 7:15 a.m. before Jennifer went off work, because Lucy Letby wanted to say hello. And in the agreed facts, it says that when the nurse's back was turned, the baby had this desaturation. But if we look at Jennifer Jones Keys' statement, she says that when she came on and took over the care of baby N on the night shift of the 14th of June, there were no concerns for baby N at the handover. But she writes retrospectively at 5:51 a.m. on the 15th of June that just after 1 a.m. the baby looked very pale, mottled and veiny. So the baby clearly didn't look well. And she recalls that over that morning, baby N started to have these desaturations that were being picked up now, and the baby was put back on full monitoring. So the baby had clearly declined. And then she says that baby N had settled down, but from 7 a.m. onwards was having more desaturations. So the baby was deteriorating over the entirety of that shift. Then Letby comes in to say hello, and at that point she said, I think the monitor went off. So Lucy went over to see. He went quite pale. I think he'd stopped breathing. I got the neopuff. The prosecutor continues to try and get Jennifer Jones Keys to say that Letby had done this when her back was turned, but that clearly wasn't the case, because she stated that she came in to say hello because we hadn't seen each other for a long time. We were good friends. Lucy Letby was very competent. The alarm went off and we both reacted to the alarm. That's what happened. And Myers, the defense, sums it up that they both responded when an alarm went off when Letby was there. The person present at this so-called incident agreed that that was the case. And why wouldn't it be the case? Because the baby has been progressively desaturating all night and is under perfusion, building up acid in his blood, and is eventually going to collapse, which it did. And now, because that situation was allowed to happen all night, the reaction of the medical staff to this situation is going to have to be more extreme than it might otherwise have been. Then we get the evidence from Dr. A, and this is the guy who can't be named for legal reasons, and he's talking about the events of June the 15th, and the medic tells the court that he recalls baby that he had trouble trying to intubate the baby. He says, which is not a frequent occurrence for him. Well, good for him. And the notes from the early hours of June the 15th show that the doctor ordered a blood test for baby N because he was mottled in appearance and he wasn't sure why. The mottling eventually resolved, but over the next few hours, baby N suffered 5 desaturations. The doctor then says that because of this, It made him think that the baby had an infection. And why wouldn't it? And he tells the court that results ruled out infection as a cause. But I've told you many times on this that these results can't rule out infection. We haven't reached the stage yet where we've got decent biological tests that we can do and say yes or no that a baby has infection. Infection is largely a clinical diagnosis. They did a septic screen, but they don't say whether they started the baby on antibiotics or not. I don't know. It doesn't say here. And they decided to move the baby to nursery room 1. And it's notable that when they moved the baby to nursery room 1, they also changed the nasogastric tube from the left side to the right side. So why did they do that? That should have been gone into, because that's another invasive procedure carried out on a baby that has haemophilia. So was there a problem with the NG tube? Had it caused damage to the nose, to the throat? Because they've now changed it. Something prompted them to change it. But the most common reason for moving a tube from left to right is because of nasal irritation or trauma to the nostril, which could easily result in bleeding in the mouth. And no matter how well you put the tube in, you have to take into consideration the difference between a preterm neonate's mouth, throat and airway compared to an adult or an older child's. This tube has obviously been in for a while, and the baby is also receiving bottle feeds. The epiglottis is the flap of tissue that closes over the trachea when a baby is swallowing, or when anyone is swallowing, to stop food going into the lungs. In the little preterm babies, the epiglottis is omega shaped, so that's like a horseshoe. It's longer, narrower and larger compared to an adult, and it's less flexible because it doesn't have enough elastic cartilage, and that makes it floppy and difficult to manipulate. But it also means that it's invariably going to rub against the NG tube because it can't avoid rubbing against the NG tube. That entire area is about 3 millimeters wide. The NG tube is now going to take up 1/3 of that area. And there's a huge difference in where the epiglottis is depending on how the baby is breathing. If the baby's lungs are aerated, if they're filled with oxygen or air, the epiglottis is going to be open about 70% of the time, moving it away from the NG tube. If, on the other hand, the lungs are not aerated, in other words, we have a desaturation and the baby isn't breathing right, the epiglottis will only be away from the back of the throat. It'll only be open for about 17% of the time, so it's going to be rubbing more frequently on this NG tube. And because of all of these anatomical differences, you have to use a different laryngoscope to open up the baby's mouth and get a tube in. So did the Countess of Chester Hospital have what's called a Miller laryngoscope, a straight laryngoscope? Or did they try and do this with a curved laryngoscope, which is not going to work? We don't know, but we should find out. And the doctor tells the court that his decision to intubate baby N and put him on a ventilator was hampered by an unusual swelling and blood in the back of the baby boy's throat. After 3 unsuccessful attempts to intubate, the doctor abandoned the procedure. His notes from that morning stated, intubation abandoned due to blood present at oropharynx and likelihood of trauma due to repeated attempts. That's what he wrote down. Likelihood of trauma due to repeated attempts in a baby that has haemophilia. And Myers, for the defence, he asked him when he saw blood in baby N's throat. And Dr. A says, I believe blood was there at insertion attempt number 1. And Myers says to him, if you can't see it, you wouldn't attempt it. So I presume he means if you can't see the vocal cords. And he replies, you can do if quite certain of the position. But you obviously weren't certain of the position because you failed 3 times to put the tube in. And Myers then quotes him back with his own words that he gave in a police statement in 2018. In that statement, he said he was not sure if the bleeding was his fault due to his attempts to move the tongue with a medical implement to intubate. He's not sure. That is all we need for reasonable doubt. The baby has been sick all night. The baby has got sicker. They have decided to intubate. They have to get the trolley ready to intubate. They have to get all the sterile stuff. There has to be someone with the baby all the time. No wandering off to see what other babies are doing. This baby is in serious trouble. Someone has to be with that baby all the time. And nobody witnessed Lucy Letby thrusting anything down the baby's throat. The doctor has admitted that the most likely cause of the bleeding was traumatic injury, iatrogenically caused by him trying to intubate the baby when he clearly wasn't able. Letby will subsequently be found guilty for this indictment based on the nonsense and lies that Darry Evans told. Weirdly, this doctor also said in his evidence that he was worried that there was some concern about blood not being delivered to the skin in a way that would be normal. That's not a way that a doctor speaks, because he goes on to use the proper vulgar term in medicine to say that the baby's mottling had returned. But we know, and he should know, that mottling is the sign of the onset of shock in the baby. There's nothing unusual about it. Blood can only get to the skin the same way it always gets to the skin. And when there's not enough blood to go around, the skin is the first part of the body that's sacrificed. The drop in blood pressure that's coming with this mottling is causing the blood vessels in the skin to close down and hold on to deoxygenated blood too long. And this is going to create the optical illusion that we have talked about before, that is cyanosis. Dr. A, too, it appears, is not immune to a little bit of spectral medicine when the occasion calls for it. And by the way, the medical term for swelling is edema. And there are a limited number of things that are going to cause edema in a preterm baby. So we can put them in order. Infectious causes wouldn't be particularly common in preterm babies, but when you're putting down feeding tubes that are 89% contaminated with biofilm, they're probably going to be more common. And the usual species is Haemophilus influenza, Streptococcus, and Staphylococcus. These are really common bugs that could easily make their way into biofilm. But Pseudomonas itself, the pathogen rampant on this ward, can cause epiglottitis as well. Can cause acute epiglottitis in these babies. And they can get viral infections. But there are non-infectious causes. Reflux, feeding tubes. They can cause mechanical irritation and subsequent edema of the epiglottis. Trauma from medical procedures, such as intubation attempts or suctioning. They can cause injury or edema, inflammation, edema. But we have to also look at the anatomy of the epiglottis in a preterm neonate. It's much more floppy, it's broader and longer compared to older children. And because of that structure, it's not compliant, it's movable. And that makes it more prone to swelling. And even small amounts of edema can significantly narrow or compromise the airways of these babies. So why did Dr. A not use proper medical language such as anatomy, physiology, pathology to explain what the likely cause of edema or epiglottitis is in a preterm neonate. Then we get on to Dr. Gibbs, who gives us a real howler and tells us what is wrong with this unit. And retired consultant pediatrician Dr. John Gibbs is now in the witness box, blah, blah. Citing his notes, Dr. Gibbs recalls that a specialist team had been called to help doctors with baby N's breathing due to various problems with trying to intubate, failing to intubate. The team from Alderhead Children's Hospital arrived at 9:20. They were made up of experienced intensive care consultants and an ear, nose and throat surgeon. Well, there's the admission that the people like Dr. Gibbs and Dr. Beery and Dr. J. Ram and all these other people were not experienced intensive care consultants. And the plan was to try and intubate the baby, and if that failed, do an emergency tracheostomy. So that's why they dragged an ENT consultant all the way from Alderhay to Chester, because they knew the baby's epiglottis was so swollen, full of edema, infection, inflammation, reflux, whatever, that it was going to be very difficult to intubate the baby, and that even the consultant from Alderhay may not be able to do it, and they'd have to do a tracheostomy. Probably the only time these people have ever thought straight about anything. But we have the admission here. Dr. Gibbs also thinks that the bleeding could have come from the lung. I have no idea why he would say that, but that's what he said. And in the end, I don't think infection was the cause of baby N's collapse. This is always the thing with these people. The babies die with pneumonia, not from pneumonia. I don't think he had infection. It's clear to anyone who has ever dealt with these babies or has ever dealt even with adults that infectious diseases behave this way and can come on this quick. And then we get Stephen Beery. Can we believe what Stephen Beery says? I don't know. The Thirlwell inquiry is throwing up a lot of questions about that. He says that he was called to help and he made an unsuccessful attempt to intubate the boy. He tells the court, from reviewing the notes, it wasn't successful due to blood and swelling in the back of the baby's throat with blocked vision of his airway. And of course, well, when was he? 5th or 6th in line to try this? And Mr. Myers is now questioning Beery, and he's asking him about baby N's blood disorder and the increased risk of bleeding. And Myers is taking the court back over notes of that day that show there were 7 attempts to intubate baby N before the team from Alderhay arrived. 7 attempts. But Dr. Beery goes on to say that he can think of no natural, normal cause for why baby N deteriorated multiple times and then improved afterwards at Alderhay. I can think of plenty. One of them being that the baby was being cared for in a shithole, that there were nurses looking at him every now and again. The baby clearly deteriorated on the 14th when Lucy Letby was nowhere near the baby. So if there's no natural or normal cause, it wasn't Lucy Letby that caused the unnatural or normal cause, because she wasn't there when this deterioration started. But there are natural, normal causes. The same things we always see. Infection, inflammation, and iatrogenic trauma. That's the evidence I would have given had I been asked. This is all one big yarn as far as I'm concerned, and it just shows the way that this hospital was run, that they couldn't detect babies becoming ill. They didn't know how to respond when they did become ill. They didn't know how to manage the decline of the babies, and in the end, they had to be bailed out by a specialist team, meaning that the baby should have been in Alderhay all the time. But we'll just do Sally Kinsey before we get to Dowie Evans. And Professor Sally Kinsey The professor that I like to say always that she thinks venous blood is blue. She's a blood expert, of course, and baby Anne has a rare blood disease. And Professor Kinsey is explaining to the jury that this can cause catastrophic bleeding following minor injury. Baby Anne had a moderate variant of the condition, she tells the court, which is contrary to what the prosecution told the court, that the baby had a mild version. Professor Kinsey is asked whether the blood seen in baby Anne's throat that day could have been caused as a result of self-injury or spontaneous bleed due to a blood condition. And she says no. Let's just quickly go to the NHS page on the subject of haemophilia, and it says the symptoms of haemophilia depend on how severe the condition is. The main sign is prolonged bleeding. This bleeding may happen spontaneously. For example, this could be sudden nosebleed, bleeding gums, bleeding inside your joint and muscles. The bleeding may also happen after a medical or dental procedure, such as having a tooth removed. So the NHS says that moderate haemophilia can cause spontaneous bleeding. But Dr. Kinsey obviously doesn't agree with the NHS. Let's have a look at a lovely paper written by a Dr. Helen Dyson. Neonatal Haemophilia, a Guide to Recognition and Management. A wonderful piece of writing, if I can compliment her. And she says that the presentation of haemophilia in neonates is different. Bleeding in neonates is not an uncommon problem. Pulmonary hemorrhage, gastrointestinal bleeding, bleeding from venipuncture, bleeding from into the brain occur relatively frequent in preterm babies and in term babies with infection or hypoxic ischemic injury, which we're witnessing here. And in these circumstances, bleeding usually occurs as a result of acquired conditions such as thrombocytopenia, that's low platelets and disseminated intravascular coagulation. That's the problem that you can get when you have sepsis, that gives you a purpley pink rash and all that stuff. And these infants are often unwell. By contrast, haemophilia often presents as unexplained bleeding in an otherwise well infant. And she goes on to say that rarer presentations include spontaneous gastrointestinal bleeding, intrahepatic bleeding, so that's into the liver, splenic hematomas and rupture, so a hematoma is a build-up of blood, adrenal bleeding, and spontaneous superficial hematomas, which is something in the back of your throat because it's superficial. She also helpfully tells us that mothers who are known carriers of haemophilia, baby Anne's mother, should be booked to deliver in an obstetric unit at a haemophilia centre for both their own and their child's benefit. Let's look at another little paper here, which is called Laryngeal Edema in Neonatal Apnea and Bradycardia Syndrome. That would be desaturations. And the purpose of the trial was some preterm infants in general good health continue to present with recurrent apneas, bradycardias and desaturations, ABDs, despite usual treatments. These events may lead to transitory brain hypoxia and to further neurological injury. The purpose of this study has been to evaluate the role of laryngeal edema in the symptomatology and to assess corticosteroid treatment. So they looked at 12 babies. I know it's a small number, but they looked at 12 babies, range age between 26 and 35 weeks, that already had signs of desaturations. And they did fiber optic laryngeal endoscopies on these babies. And the result was that each baby presented a severe laryngeal edema compatible with potential obstructive breathing. Each one of them. Half of the cohort received inhaled steroids and all the babies improved. The other half received only topical corticosteroid treatment, as 4 of the 6 babies improved and 2 needed oral dexamethasone, dexamethasone being a very potent steroid. So we have a proven connection between laryngeal edema happening spontaneously in babies and causing desaturations. Let's have a look at another paper from 2021. And this is released from the British Library, and it's called The Neonate with Haemophilia. And a section from the paper says, a recent review of neonatal bleeding in babies with haemophilia notes that the commonest site of bleeding is the cranium, with intracranial hemorrhage accounting for 27% of all bleeds and extracranial hemorrhage accounting for 13%. However, in one Swedish series, 75% of all cranial hemorrhages were extracranial, and it is possible that extracranial hemorrhaging is underreported. Iatrogenic bleeding, including bleeding from puncture sites, vascular, capillary, and intramuscular, in 16% of infants, and from circumcision in 30%. The latter figure will be considerably lower in countries where early circumcision is not customary. Umbilical stump bleeding was rare, as were gastrointestinal and mouth bleeds, parenchymal bleeds, joint bleeds, and ecchymosis, and these are spontaneous. So rare they might be, but so too is haemophilia. But we have to consider all the factors in relation to hemostasis, that's prevention of bleeding in preterm neonates compared to adults and term babies. So the stages of clot formation are vasoconstriction. So that's the first thing that happens when you cut yourself, is that the blood vessel around the area where you've cut yourself will start to constrict, and that will reduce the flow of blood. And then the platelets, they activate and they stick to the injury site and attract more platelets to them, and that's called the platelet plug formation. And then we get the activation of the clotting factors. So these are proteins that are made specifically to form a compound called fibrin. And fibrin is what causes a more permanent type of clot in a process called clot stabilization. So it forms a mesh around the platelet plug and reinforces it. And after that, you get what's called clot retraction, and the clot shrinks, pulling the edges of the injured blood vessel together to slow down bleeding further. Then, as the healing progresses and the clot is not needed anymore, you get fibrinolysis, which is the dissolution, really, of the stabilized clot. But in preterm neonates, regardless of whether or not they have haemophilia, which is only going to add to the problem, preterm neonates have underactive platelets, so they're not as efficient in forming platelet plugs. The levels of most of the coagulation factors are decreased by up to 50% of normal in adults, and the vitamin K dependent factors are particularly low. And there are these other proteins called natural anticoagulants, and they form a kind of secondary part of the process of forming these clots, and they're deficient as well. Preterm neonates also have a higher factor of what's called von Willebrand's factor, and an increased hematocrits and larger mean corpuscular volumes. So these are characteristics and properties of the constitution of its blood that's different, and these actually act as compensatory mechanisms and can, in most cases, preserve the ability of the preterm to form a clot and stop bleeding. But despite these differences, The preterm neonate's balance is more fragile and can be easily disrupted by external factors, stress, illnesses, and leaving them overall more vulnerable to problems with hemostasis. So preterm neonates, including baby N, are much more likely to bleed spontaneously or from any medical procedure that's carried out on them. So Professor Kinsey, venous blood is blue, is incorrect and misdirected the jury when she said that the babies wouldn't bleed for no reason. Spontaneous bleeding is less common in moderate haemophilia patients compared to severe ones, obviously, but it does happen. And we'll leave you the link to all this. So if the jury's sitting there being told by an expert that these babies don't bleed for no reason, they weren't being told what the literature actually says. And then we get to the genius that is Gary Evans, and he's now in the witness stand, and he was asked to review the case by Chester Police. Yeah. Dr. Evans' opinion is that bleeding in baby N's throat was not caused by the attempts to intubate, but instead some preceding trauma. Dr. Evans said baby N's progress was pretty uneventful and was making satisfactory progress for a baby that was premature but otherwise well in the weeks from birth to the 15th of June. And that is clearly untrue because the child became ill on the 14th, and I'm pretty sure if you look at the notes in detail, it will have become ill on the 13th or the 12th, not the 15th. Court is being taken back over timeline of baby N's crashes on the 15th of June and ignoring the 14th of June, which culminated in cardiopulmonary resuscitation and him having 6 doses of adrenaline before he eventually transferred to Alderhay Hospital. Much of that due by Dr. Gibbs's own admission to the incompetence of the people in the County of Chester Hospital. And Dr. Evans is giving his analysis of baby N's first collapse on June the 3rd. The baby suffered a profound and sudden collapse in the early hours of that day. Remember, I told you in the podcast yesterday, 60 TSAT per day these babies get. This was preceded by what one doctor recalled as screaming. Dr. Evans said that it is very unusual for a child of this age to scream, which begs the question straight away before he continued with his invention. What is a scream? A publication in 2015 of work by neuroscientists David Popple and Luke Arnold described screams not as we had previously thought they were. So they published their findings in the Journal of Current Biology. And on the surface, screams, according to them, are a simple concept. They're loud, high-pitched, and intended to convey extreme distress or danger. But conventional wisdom aside, the scientific community never settled on a concrete definition, nor did it explain our response to screaming. This came as a surprise, of course, to these researchers from the University of Geneva, and they conducted a highly unconventional acoustic study, collecting a host of different human and non-human sounds. Another group listened to the sounds, rating them based on how alarming they were. And as it turned out, a true scream isn't characterized by volume or pitch. The real key is an acoustic feature called roughness. And when the frequency of a sound modulates, that means when it changes from one frequency to another more quickly than our ears can differentiate, it's considered rough, and we perceive it as unpleasant. And hearing very rough sounds is correlated with activity in the brain's amygdala, a region associated with feelings of fear. Screams, along with dissonant chords and artificial alarm sounds, all the different things that can make us feel cringy, all fell within what they call the roughness domain. And the more that roughness modulation the sound has, the more scary it seems. and the more effectively it activates the amygdala in the brain. And they said that screams occupied a privileged acoustic niche, completely separate from the frequencies found in speech and gender-associated modulations. So most of us know what a woman's voice sounds like versus a man's voice, and sometimes there's an overlap. Those characteristics are determined by frequency modulations, changes in pitch during the vocalization that the ear can differentiate. A scream, on the other hand, is a frequency modulation, as I said, that the ear cannot differentiate. And strangely enough, the fundamental frequencies of screams are not the high-pitched squealing sounds that we associate with screams, but they're actually very low, 30 hertz to 150 hertz. The lowest frequency on a bass guitar, the E note, the lowest note on a 4-string bass guitar, is 41 hertz. And the range of the roughness range of this acoustic niche that characterizes screams is between 30 and 150 hertz. Preterm neonates can produce frequencies in and around 50 hertz, so they can produce frequencies in the roughness range. So it's perfectly feasible that a preterm neonate can produce what an adult will perceive as a scream. And in addition to that, they produce an early form of vocalization called protophones. That's protophones, and we've talked about these before. Protophones you could think of as an early attempt at vocalization, of actually using the voice to achieve a goal. And preterm neonates produce thousands of protophones, including squeals, vocans, and growls from as early as 2 months before term. And they're far more frequent than cries in preterm babies. Even the youngest ones that are only 24, 25 weeks, over 80 protophones per waking hour these babies produce. So there again is no magic to this concept of screaming. Screaming is very much like colour, a perception that a person has, and it even has different perceptions in different societies. Screams are also a way of expressing different emotions, including fear, pain and anger, the usual thing, but also surprise and happiness. And screams are universal across humans and most animal species. They're often involuntary or reflex actions, so they're not driven by anything, and they can essentially be produced in any creature that has lungs. So if you combine the ability to produce this roughness in the voice very easily in preterm neonates, along with the higher frequency of protophones that produce squeals, it isn't difficult to see how you might mistake or misinterpret a combination of growls, that's the 30 to 150 hertz undifferentiated modulation, combined with protophones. So there's your scientific explanation for the spectral presence of screaming that Dowie Evans will go on to suggest is only caused by a baby suffering. It's not only caused by a baby suffering, according to people who have actually studied this subject. Not make it up as you go along, people like Dowie Evans. And then he goes on to produce what I am pretty certain is a complete fabrication. He says that he came scientific papers, as it's reported here. He went and reviewed scientific papers on air embolism, that's the injection of air, which is not the injection of air. And these found that in some cases where babies had been injected accidentally with air, There were periods of screaming before desaturation and death. So I cannot find any association whatsoever with air embolism and screaming. So I'm pretty convinced this guy made this up. And if he didn't make it up, I will withdraw that comment if he'll show me the paper. But it isn't part of what people would regard as a group of symptoms or observations or findings that would occur with air embolism. It's part of the story of this trial. And he goes on to say that what happened to baby M was repeated in what had been seen in previous cases. And of course it was, because all of these cases are constructed, and they're constructed in order to be repeated. And on the 15th of June incident, Dr. Evans said in his opinion the bleeding was as a result of trauma to his upper airway. But we know that it was the result of trauma to the upper airway and the haemophilia. But we don't know if the baby had infected or inflammatory epiglottitis, and neither does he. So we go into Ben Myers' cross-examination, and not surprisingly, he points out that Dowie Evans wrote several reports on the collapse of baby N. In the first report, written in 2018, Evans didn't mention the incident of the 3rd of June. He tells Mr. Myers that he overlooked it and later included it in subsequent reports. What a joke. Mr. Myers said, if you considered it significant, you would have said so in your first report. Absolutely, you would have said so in your first report. Mr. Myers put it to Dr. Evans that there is nothing in the medical notes for child N to support a suggestion that there was an inflicted injury. And there isn't. There's nothing. And Dr. Evans disagrees. Of course he disagrees. He says that his opinion when he authored the report in 2019, that is his opinion now. But what will his opinion be tomorrow? Because we know that he changed his opinion in the case of BBC. The man simply has no scientific credibility whatsoever. On whether baby N had received an injection of air on the 3rd of June, Mr. Myers put it to Dr. Evans that there was no evidence of an injection of air, and the medic was attempting to work a piece of evidence in to support his theory of air embolism, which is exactly what he's doing. But strangely, in this case, the jury didn't buy it. And we don't know why the jury didn't buy the first indictment. He disagrees, and he says that he was applying standard clinical practice. Was he bullshit applying standard clinical practice? In his review, he said he was written with knowledge of previous babies in this case. That is not standard clinical practice, to get a bunch of babies together and work everything out so that they all fit into a pattern or a picture. Every patient that presents to you with a clinical problem, or that you observe with a clinical problem, is dealt with on an individual basis. You might fall back on previous knowledge you've had or previous experience you've had, but you're applying that in general to the patient in front of you. That's standard clinical practice. I think we have to seriously consider that this baby was a victim of air embolism on June the 3rd. What a joker this guy is. Mr. Myers has just been questioning Dr. Evans about how he was approached to review these cases. Myers pulls up the infamous email after Evans said that he had been approached by Chester Police. And the email was from 2017 that Evans sent to the National Crime Agency, telling them the death at Chester sounded like my kind of case. He accuses Dr. Evans of touting for work and says he was using his review to fit the allegations, not the facts. He put it to him that air embolism was mentioned to him by Chester Police before the review. He denies this and accused Myers of going on a wild goose chase. Well, if there's anyone who knows more about wild goose chasing, more than Dowie Evans, I don't know. On Tuesday the 6th, jurors were read an email sent by Evans to the National Crime Agency in May 2017 ahead of his involvement with Cheshire Police. In his message to Nick at the National Crime Agency, National Injuries Database, so we're onto the National Injuries Database straight away, long before the trial. Dr. Evans wrote, incidentally, I've read about the high rate of babies in Chester and that the police are investigating. Remember, I mentioned in a previous podcast as well that Professor Fenton and Scott McLaughlin had also reported that the Countess of Chester Hospital was far from the highest number of deaths in neonatal units in that period, 2015, 2016. I wonder why Evans didn't notice any of them. Do they have a pediatric neonatal contact? I was involved in neonatal medicine for 30 years. I think he's overpadded the CV there, but including leading the intensive care setup in Swansea. I've also prepared numerous neonatal cases where clinical negligence was alleged. If the Chester Police had no one in mind, I'd be interested to help. Sounds like my kind of case. Like, why would Chester Police go after a guy who seriously has retired for 15 years? Why would they not go to someone like Svelena Dimitrova, who's working with the Ochudin report and who's working currently and investigating all of these things? Why would they not look to the Royal College of Pediatrics and Child Health and say, can you advise us on somebody to look at these cases? No, they had to go for this guy here who makes stuff up and then pulls it away when the case is over. He never really seems to know when to shut up. I understand that the Royal College of Pediatrics and Child Health have been involved, but from my experience, the police are far better at investigating this sort of problem. This is what Evans is saying. Ben Myers, KC defending, says to Evans, this is you putting yourself forward and in fact touting for this job. And Evans replies, I was offering my professional opinion if that was in their interests. Well, it was very much in their interests, wasn't it? Because they gave you the job. Mr. Myers said, it's you ready to give them what they wanted, Dr. Evans. And the witness said, no, I have dealt with several police cases where I have said this case doesn't cross the threshold of suspicious death or injury or whatever. He always throws in this whatever, like injected with or something else. Injuries, suspicious deaths or injuries or whatever. My opinions are impartial and independent. Yeah. And if my aunt had balls, she'd be my uncle. I also give evidence to law firms representing the defendants. In the past 5 years, I've given more reports relating to defendants to the police or the prosecution. Mr. Myers went on, at some point before you started writing reports, you were told by the police about suspicious rashes in our embolism, weren't you? And Evans says that's completely untrue. It's totally untrue. Thou dost protest too much. The first time I heard a local doctor mention our embolism was a couple of weeks ago. And we are supposed to believe that. I am being asked as a rational human being to believe that. The man who walked into Cheshire Police Station and diagnosed our embolism within 10 minutes of looking at these notes, I'm supposed to believe that. The first person I know to raise the area of our embolism was me. I did that in case number 1. Yeah, the index case. And I thought, oh my God, what is going on here? Well, he ignored everything else in the case. He just went straight to his little theory about our embolism. Even if he had done that, even if you come up with a hypothesis or a theory, you're then meant to work back and work it out. And you can't work it out from the evidence in the case of BBA. There simply isn't any evidence of our embolism in the case of BBA. It's not there. I was not told anything about any suspect. I knew absolutely nothing. He had the files with Lucy Letby's name in them. He had all the files. Then finally we go to Dr. Sandy Bowen, who also reviewed the case and is now in the witness box. She said the bleeding referred to by BBN on June the 15th could have been caused by local trauma to the mouth. On the incident of the 3rd of June, Dr. Bowen says she has never experienced a neonatal baby crying for 30 minutes. That's because there isn't a neonatal baby that cries for 30 minutes. They can cry for periods of 30 minutes, but they do not cry for the totality of 30 minutes, which is what she's trying to imply. She says it is an extraordinarily long time. Yes, it's an impossibly long time. And she puts it down to an inflicted painful stimulus when I've just told you that screaming is not necessarily associated with distress or pain, according to people who study screaming. I just call it a halt here. Again, there's absolutely nothing in this indictment or these three indictments that I think make the threshold of a crime. But there's lots of evidence of inadequate care for the baby. The baby should never have been in the Countess's Chester Hospital with haemophilia. We don't know if the baby needed treatment for haemophilia. We don't know anything about this case. We need to get a lot more information about what went on, and I'm sure in the drawer of doom this information exists. Lucy Letby, interestingly, in one of the text messages, noted that baby Anne had suffered a kind of seizure where it went very rigid and that its movements were spastic type movements followed by flaccid type movements, which could indicate that the baby did actually have an intracranial hemorrhage. And I don't know what the condition of baby Anne is now because it's secret, and anyway, it isn't any of my business. But if it is the case that baby Anne has suffered from intracranial hemorrhage, that family should sue this hospital, in my opinion, because they should not have had this baby or this mother from the very beginning. And that is another feature of all of these cases that we keep coming across in the Letby series. So again, I hope you learned a little bit from that, how just with the application of simple science we can explain all these events as a more rational alternative to the lunacy of Gary Evans. So in the next episode, episode 43, we'll move on to the case of baby O, and after that, baby P and baby Q. So I'll see you in the next episode. Bye.